So without further ado, I'd like to hand over to Professor Guy Leschziner. So he's a neurologist and an author and has written widely on sleep, who will be talking to us about managing sleep disorder in the clinic.
Thanks very much for inviting me to what I always hold up as the best conference in London. I'm slightly galled by seeing so many old bosses and colleagues in the audience, which is slightly off-putting. So I'm going to start off by teaching my grandmother to suck eggs, and just to really highlight the impact of acute and chronic sleep loss on various psychomotor features, all of which seem to prime individuals for issues with their psychological health. And of course, you'll all know that insomnia is an important risk factor for mental illness, and the evidence points to that being strongest for depression, and that also insomnia is a significant risk factor for suicidal ideation and behaviour, which is why it's very important to assess in the neurology clinic, in the psychiatry clinic, and in the neuropsychiatry clinic. In other settings, obviously, sleep issues are of fundamental importance in, for example, my epilepsy clinic, or in seeing individuals with migraine, stroke, dementia, Parkinson's disease, and of course, traumatic brain injury, which we may hear about a little bit later. And in the neuropsychiatric setting, sleep is often a major issue in FND and non-epileptic seizures, and also fatigue syndromes, although, of course, at the moment, it remains uncertain whether or not that association is simply an association, is causal or contributory. So, if there is one message that I want you to take away from this talk, is this message, which is that not all insomnia is insomnia. There are many other sleep disorders that can present with insomnia. Conditions like obstructive sleep apnea, which is seen in about 40% of people with insomnia, and this actually has a diagnostic label now in the literature termed COMISA, so comorbid insomnia with apnea, or INCOSA, which is insomnia with comorbid obstructive sleep apnea. In fact, obstructive sleep apnea can present with a phenotype that is very difficult to discriminate from in the clinical setting from insomnia. I see a number of individuals who are referred in with profound insomnia. You do a sleep study, and we can talk about when to do a sleep study, and you find out that they've got really bad insomnia and of course really bad OSA, and their insomnia resolves as soon as you treat their obstructive sleep apnea. In fact, conditions like restless leg syndrome and periodic limb movement disorder can also present with insomnia, and rather counterintuitively, we often see individuals with these kinds of motor disorders of sleep or wakefulness presenting with significant hyperarousal or hypervigilance. And so there is a cohort of individuals with periodic limb movement disorder who will complain of insomnia. They will be unable to fall asleep during the day and will also report hyperarousal responses to bed. So the first question really is when to consider an alternative diagnosis for individuals with insomnia. And obviously the best way of doing that is by taking a clinical history. So if there are even very mild indicators pointing towards conditions like obstructive sleep apnea or periodic limb movement disorder, that would certainly make me want to do a sleep study. If there is an absence of very prominent sleep initiation difficulties, so if the predominant picture is of sleep maintenance issues rather than sleep initiation, and if there is an absence of hyperarousal in particular, then that would make me want to do a sleep study. One very useful way of trying to ascertain whether or not you can be sure that an individual is describing insomnia disorder uncomplicated by other sleep pathologies is the presence of preceding sleep reactivity. So the kinds of things that I often ask for are things like, if you have to get up very early to catch a flight, how do you sleep? If you have an exam or a job interview the following day, how do you sleep? What are the impacts of daytime stress on your sleep? So in the absence of those kinds of features, that again raises my clinical suspicion that what we're dealing with potentially is either something other than insomnia, or that there is a sleep pathology associated with insomnia. And of course, the presence of daytime sleepiness. So most people with insomnia, and this is not a hard and fast rule, but really the vast majority of individuals with insomnia will say they feel terrible during the day, that they feel like they want to sleep all the time, and they will then, but when you ask them, well, do you actually nod off? If you go and lie down in bed, will you fall asleep? They will say no. And so most individuals with pure insomnia will have Epworth scores that are 0, 1, 2, rather than 7, 8 or 9. And it is always worth revisiting the Epworth score with individuals in clinic, because what people with insomnia will often say is they will initially describe very raised Epworth scores, but if you clarify with them whether or not they've answered it in the way that they should be answering it, i.e. do you actually doze off, do you actually fall asleep, or is it just that you feel like you want to close your eyes, you'll often find that their Epworth score drops dramatically. So it's really worth going back to that Epworth score and going through it with them. So I'm not going to run through all the treatments for insomnia, but I thought I would at least discuss this drug, which many of you will have come across, you may have prescribed it, which is a relatively new contribution to our armamentarium in terms of treating insomnia. This drug, daridorexant, is a dual orexin receptor antagonist. It works on the orexin detecting cells in the lateral hypothalamus, which is at the core of regulation of wake and sleep. So it's implicated in suppressing REM and also suppressing non-REM, depending on which of the two orexin receptors are primarily triggered. This drug binds to both receptors and is really a drug unlike the existing drugs that we have available. Although in the US they have had dual orexin antagonists now for about 10 or 15 years. This is the first drug that has been available here. It's been around for just over a year and a half. It was approved by NICE in very early 2024, and NICE have given it rather specific indications, so it can be used in individuals who have insomnia for more than 3 months, more than 2 nights of the week. They must have either failed CBTI or where CBTI is unsuitable or unavailable. And these individuals, according to the NICE guidelines, should be reviewed after 3 months to assess response. I think that's probably to do with financial implications of leaving people on this drug if it's not working. So this is one of the original studies that led to the approval of daridorexant. It's very, very small, and I don't expect you to read all of this, but actually for most of the side effects that are listed, they're not significantly greater than in the placebo arm. There are, however, a few important features. So what you can see here, this study was done over 3 months, and you can see a sustained response both in objective and subjective measures of sleep, both in terms of the wake after sleep onset, in terms of the latency to persistent sleep, and in terms of the total sleep time. And you can see that those improvements are sustained with very little evidence of habituation or tolerance, which is often a problem that we encounter with many of these other drugs. Unlike standard sedatives, when we look at sleep architecture in individuals on daridorexant, there is clear stabilization of sleep across most of the transitions between wake and other stages of sleep, so it seems to be slightly kinder on sleep architecture than drugs like benzodiazepines. And in the long term, we see that this was a study that looked at individuals in Japan who were started on daridorexant and took it over a year, and again you can see sustained responses, and importantly, when the drug is terminated, you don't see massive rebound insomnia, which is often a very potent driver for not being able to get people off things like Z drugs and benzodiazepines. So on many levels, this is potentially quite a useful drug. In terms of those potential benefits, well, I've talked about a few of these already. It has minimal interactions, and importantly, there is now pretty good evidence that unlike many of the existing drugs that we use, it doesn't worsen obstructive sleep apnea, which is a major consideration in the sleep clinic. Major side effects, well, occasionally we do see people with morning sedation, although much less frequently than with drugs like zopiclone. And one of the biggest issues is that individuals will often complain of very vivid dreaming. So it's probably not an ideal drug to use in individuals who have comorbid nightmare disorder. There is emblazoned across all the literature and also in FDA literature and in MHRA literature around suicidal ideation with daridorexant. In fact, a very recent study that looked at the FDA reporting system suggested that daridorexant was not associated with suicidal ideation and indeed may be protective of suicidal behaviour. So I think that whilst we are still duty-bound to warn people about the risk of suicidal ideation, I think in reality that is significantly overplayed. So that's the sort of the headlines surrounding daridorexant. I've now prescribed this drug in about 300 individuals. And I think the reality is perhaps a little bit less attractive than the headlines. It works really beautifully well for about 60 to 70% of individuals. But for about 30%, it makes absolutely no difference whatsoever. It's as if you've given them less than a placebo. And there are a few individuals, particularly those individuals who are in very heightened anxiety states with significant hyperarousal, in which occasionally you do see a paradoxical response to daridorexant. They often will complain bitterly that as soon as they've started it, they've slept much worse than they did before. So it is worth warning individuals about that. The other features are that daridorexant, for reasons that we don't fully understand, first of all, in some individuals can take up to a month to really demonstrate any significant improvement. And so my practice is a little bit different to what is recommended by NICE. I will review individuals after a month, first of all to ensure that there are no side effects, secondly to ensure that there is at least some improvement. And recent data suggests that there is a bit of a lag between objective improvement and subjective improvement. So subjective improvement can sometimes take up to 3 months to become properly apparent. So it is a very good drug to consider, but it's not the panacea to insomnia. There are additional roles for daridorexant, so there is some evidence that it can be useful in major depression. Sorry, I've skipped ahead. So there is, it can be used in Alzheimer's disease. So a few years ago, we were involved in a trial looking at another DORA that was not available in the UK in Alzheimer's disease, and some evidence that it can help in those individuals. It can be useful in epilepsy. In fact, there have been some preclinical studies that suggest that these drugs directly increase seizure threshold, and also in migraine. The other indications potentially are individuals with circadian rhythm disorders, in that we spend a great deal of time trying to fixate on melatonin and light therapy and sleep hygiene in terms of regulating people's circadian rhythms. But actually a very strong driver of the circadian rhythm is what time you go to sleep. So actually giving somebody daridorexant can be really helpful in terms of reinforcing their circadian rhythm. But at the end of the day, it's important not to forget CBTI, which remains the gold standard first-line treatment for insomnia. It is worth remembering that CBTI has strong evidence even in very significant mental health disorders like major depression. In fact, this study from 2016, which was an RCT of individuals with major depressive disorder, demonstrated that after 16 weeks, those individuals with depression had remission in about 44% in the CBTI group and about 36% in controls, and these individuals showed a significant improvement in sleep. So CBTI can be utilised in these cohorts of individuals, and another study actually showed that CBTI has a similar size of effect to depression to CBT for depression. There are some cautions about CBTI. So CBTI should be used perhaps in a slightly abbreviated or modified form in individuals with epilepsy, individuals with fatigue syndromes, because one of the core aspects of CBTI is sleep restriction, and that those cohorts of individuals don't do well with sleep restriction. So I'm going to move on to parasomnias now. So parasomnias, obviously one of the major issues in trying to address parasomnias or are differentiating non-REM parasomnias from those parasomnias that arise from REM sleep, in particular REM sleep behavior disorder, because they have very different implications. So all of you will be aware of the association between RBD and alpha-synucleinopathies, and so actually this is one of the reasons why the American Academy for Sleep Medicine takes the view that to make a diagnosis of REM sleep behavior disorder you need a PSG, and I'll discuss that a little bit further. So how do we differentiate the two? Well, non-REM parasomnias will typically happen once every week or so, although we do see individuals who will have frequent episodes of non-REM parasomnia, sometimes several times a night, whereas RBD tends to be a more persistent issue. It's a question of timing. The majority of our REM sleep is in the latter half of the night. The majority of deep non-REM sleep is in the first half of our night, so you can get some information about the timing of these events, although often individuals without a bed partner will not be very clear in terms of the timing. What are they doing during these events? So individuals with RBD extremely rarely get out of bed. They may fall out of bed in response to acting out their dreams, but they don't walk around the bedroom. They don't interact with the environment, open and closing doors. They don't run for the door. And so these sorts of complex interactions, for example, taking pictures off the walls or switching light switches on and off, are very indicative of non-REM parasomnias. Additionally, the type of speech is different typically. So individuals with RBD will often shout out, they'll often swear, they'll often scream, but they will very rarely have full-blown coherent sentences. So another indication. The dream mentation is different as well. So individuals with RBD will often have dreams of a narrative structure, often with violence. It will be a plot evolving in their minds, whereas non-REM parasomnias typically will be small vignettes of threat or hallucinations, things like that. They don't really have that narrative structure that REM dreams do. And then there is the association with drugs. So RBD can be precipitated by a whole range of drugs, including SSRIs, antipsychotics, and indeed tricyclics as well, whereas non-REM parasomnias are typically triggered by sedative drugs. In particular, zolpidem has been strongly associated with triggering off non-REM parasomnias later on in life. And then there are issues surrounding the history in childhood. So a lot of individuals, the majority of individuals with non-REM parasomnias will have a childhood history of sleepwalking or sleep talking or night terrors, whereas in RBD we don't tend to see that because of the association with neurodegenerative disorders and the presence of a family history, which is particularly applicable to non-REM parasomnias rather than RBD. So coming back to this question of whether or not parasomnias need a polysomnogram, and the answer for that is yes, if you believe the American Academy of Sleep Medicine, and I think that I probably do, that given the implications of this diagnosis, we probably should make sure that we actually record RBD or at least see evidence of significant loss of REM atonia. For non-REM parasomnias, it's arguable. The largest study to date was a study done in 2018 by our group, which demonstrated that you cannot diagnose a non-REM parasomnia on the basis of the PSG, because about a third of individuals who have non-REM parasomnias will not have features of a non-REM parasomnia on their PSG. But where it is useful for is in identifying triggering pathologies. In about a third of individuals, we find triggering pathologies that can be treated in order to try and address their non-REM parasomnias. Those individuals are typically older, male, they're sleepy during the day, and they're obese. And I think that that reflects the cohort of individuals that often have respiratory events that are triggering off their non-REM parasomnias. Well, what about treatment options? Well, for non-REM parasomnias, for RBD, there are limited options. We generally tend to start with melatonin because it is well tolerated, and we use it at doses of between 2 and up to 12 milligrams. Clonazepam is the classical treatment for RBD, of course, caution needs to be taken in individuals who have neurodegenerative disorders with a drug that can cause significant sedation in some individuals. Sodium oxybate has been used for some individuals with very refractory and very violent RBD with some success, but as many of you will know, getting sodium oxybate for individuals who don't have narcolepsy is quite a challenge. And of course, it's important to review any of their medications that might be triggering or exacerbating their RBD. What about non-REM parasomnias? Well, it's about addressing priming factors. So we know that for certain individuals, sleep deprivation, alcohol, and daytime stress can act as priming factors for non-REM parasomnias. Again, reviewing medications, make sure that they're not on anything that might be triggering it, like, as I said, zolpidem, and then treating underlying triggers. So basically anything that fragments non-REM sleep or causes a partial arousal from deep non-REM sleep can act as a trigger in susceptible individuals. That includes obstructive sleep apnea, it includes periodic limb movement disorder, it includes the flight path to Heathrow or a lorry rumbling past the bedroom window, so making sure that the bedroom is quiet. Oiling the bed springs is another strategy that has helped one or two of my patients. So when their bed partner rolls over on a squeaky bed, that can trigger a non-REM parasomnia. And then specific treatments. So we actually have relatively limited data. There's some data for paroxetine, there's some data for clonazepam. A few years ago, we published this paper, which was a retrospective review of 500 odd patients with non-REM parasomnias. And you can see here that we utilized a number of different agents, all of which had rather similar success rates. So melatonin, whilst historically has not been used in the treatment of non-REM parasomnias, it is usually the first thing that I would try. Clonazepam, it can be used as well, but I tend to reserve that for individuals who are putting themselves or their bed partners at risk. And then other drugs like tricyclics can be really rather helpful, as can other SSRIs. But it's a bit of a case of throwing the drugs up in the air and seeing which one you can catch. So I tend to be, in many ways, informed by their comorbidities. There are now increasingly some moves towards utilising non-pharmacological methods for treating non-REM parasomnia. So David O'Regan, who is part of our team at Guy's and St Thomas's, has developed a modified CBTI program, which he terms CBT for parasomnias, and studies suggest that this can be very successful, and that success persists long term as well. So we are increasingly utilising this modified version of CBTI for our patients. Moving on to restless leg syndrome and periodic limb movement disorder. So you'll all be very familiar with these conditions, seeing them regularly in your clinics. It's about making sure that nothing that you are giving them is exacerbating their RLS, and of course pretty much most of the drugs that we use will exacerbate RLS and PLND. The SSRIs, the SNRIs, tricyclics, even melatonin can precipitate RLS. Perhaps the worst culprits in my mind, mirtazapine is the tool of the devil, because it although it's often prescribed for sleep, people often miss the fact that their sleep is being significantly exacerbated by RLS, and the mirtazapine dramatically worsens RLS in some individuals. The other drug that seems to be a particular problem in RLS is venlafaxine. So if you must have a patient on venlafaxine, it's probably better to have them on a prolonged release preparation in the morning rather than giving it to them twice daily. The days of reaching for the dopa agonist have hopefully long gone, at least in the specialist setting. Amongst GPs, dopa agonists are still very readily prescribed because they are really the only licensed treatments for RLS, and actually nothing is licensed for periodic limb movement disorder. But as you'll all know, these drugs have specific issues, so a very high proportion of individuals will augment. So what that means is that their RLS will get more intense, they will get less relief from movement, the RLS will spread to earlier in the day and will spread to other body parts. And trying to get individuals off dopa agonists is an absolute nightmare once they have augmented. So, and then there are the issues of the impulse control disorders, which some studies suggest occur in approximately 30% of individuals, although NICE sticks to 6 to 17%. But either way, these drugs are problematic. And in fact, in the States, both the FDA and the American Academy for Sleep Medicine have really largely demoted the dopa agonists to third line, or what they term palliative treatments for RLS. They're essentially implying that they should be used in individuals who are going to die before they augment, which is never a cheery thought. So what should we be using? Well, actually, there is really quite compelling evidence that we should be, in the first instance, supplementing individuals' iron. The target ferritin in individuals with RLS should be somewhere between 75 to 100 micrograms per litre. And if it doesn't come up to that with oral supplementation within about 2 months, then we are increasingly using intravenous infusions of iron to get their ferritin up. And in some patients, that can be as close to curative as we can get. First-line treatments should really be focused on the gabapentinoids, drugs like gabapentin and pregabalin. In the US, a drug company has repackaged gabapentin and has produced a precursor in order to get a patent. There's no evidence that that precursor is any better than gabapentin itself. And then other drugs that can be really useful in these individuals. So in pregnant women with RLS, codeine is pretty much the only safe thing that we can use, although should not be used within the 24 to 48 hours before delivery. And Targinact, which is a combination of oxycodone and naloxone. The naloxone is not absorbed through the gut wall, so it actually simply is there to reduce constipation, is now a licensed treatment for severe refractory RLS. And there's an increasing move, certainly in the US and among patient populations here, to advocate for buprenorphine. Buprenorphine is problematic to prescribe in the UK, but certainly for individuals who have augmented very badly, it can be very useful in terms of trying to cover the withdrawal of dopa agonists. And then finally, some sedatives, which are the mainstay of treatment for conditions like periodic limb movement disorder, so where you're not treating RLS. And then moving on to the hypersomnias, well, you'll all be very familiar with the drugs that we typically use to provide wake promotion and to treat cataplexy. So these are largely modafinil, methylphenidate and dexamphetamine, although we have a couple of other drugs now like solriamfetol and pitolisant. None of these drugs get individuals with narcolepsy back to normal. And so, you know, the holy grail of the treatment of narcolepsy, particularly narcolepsy type 1, which we understand the pathophysiology of very, very well, is to replace orexin or hypocretin that has been missing. And that search for a orexin agonist that crosses the blood-brain barrier has very much been seen as the holy grail for narcolepsy. And a few of these compounds now exist. This compound, which was produced by a Japanese company called Takeda, actually went into a phase 2 trial. And they randomized individuals to placebo, 30 milligrams, 90 milligrams, or 180 milligrams twice daily. They used something called the maintenance of wakefulness test. So this is a test that specifically is looking at resistance to sleepiness. Individuals undergoing an MWT will be asked to sit semi-recumbent in a semi-darkened room and asked to stay awake for 40 minutes at a time with the EEG attached. And they had some secondary endpoints as well. Now, the impact of this drug was absolutely amazing. So in the placebo group, the maintenance of wakefulness test in this cohort was 4.1 minutes. So across 4 sessions, they stayed awake on average 4.1 minutes before they dropped off to sleep. Whereas even a very small dose of this compound extended their MWT to over 30 minutes, so a massive improvement. And in fact, in individuals on the highest dose of this drug, they were awake pretty much all the time. So 40 is the maximum you can score in an MWT, and they were getting to almost 40. There were dramatic changes in their Epworth score. That on the highest dose, the Epworth score dropped to 1.1. In fact, it's very rare that you get individuals with narcolepsy to an Epworth score that even approximates normal, and normal is really 9 or less. So this is really quite dramatic, and it really looks like this compound is an absolute game changer in the treatment of narcolepsy. Unfortunately, however, although it was very well tolerated, a high proportion of these individuals demonstrated really quite significant changes in their LFTs, and as a result, these trials were halted. But that's not the end of the story, because there are a range of other drugs that are currently entering into phase 2 and phase 3 trials. In fact, we've just recruited our first patient into a trial for the new Takeda compound. So if these compounds actually hold out on the promise that they give, I think these will be, as I said, a huge game changer in the treatment of narcolepsy, and possibly also other conditions. We have no data at the moment as to how effective it is in narcolepsy type 2, although of course there is a subgroup of patients with narcolepsy type 2 that seem to have a partial deficiency of hypocretin, or conditions like idiopathic hypersomnia. And really my final slide is on Klein-Levin syndrome. This is this recurrent hypersomnia that's often associated with significant dissociation, confusion, anxiety, occasional psychotic type symptoms, megaphagia, and hypersexuality or some other change in sexual behavior. This condition typically tends to occur in the teens, although it can occur at any age. We really have no fundamental understanding of what causes this condition. There are some genetic risk factors, we think. So in a large Saudi family with an autosomal dominant pattern of something akin to Klein-Levin syndrome, there has been a particular gene called LMOD3 identified, although in the greater KLS population, we've not found any variants or mutations in that gene. The largest study was an international collaboration a few years ago, where we identified variants in a particular gene called TRANK1, which seems to be associated with this condition. And interestingly, TRANK1 is also implicated in bipolar disorder. Now, that's curious because obviously there are some parallels between bipolar disorder and Klein-Levin syndrome. What is the evidence base for treating KLS? Well, actually, it's pretty flimsy. Anecdotally, there have been cases of individuals treated with lamotrigine or carbamazepine, mood-stabilizing agents, but the strongest evidence is from a paper from Isabelle Arnouf's group, where they had 130 patients who were enrolled in this open-label study, and they demonstrated that lithium at levels of 0.8 to 1.2 had a significant impact on the duration of bouts, the time spent incapacitated by bouts, and the number of episodes, so halving the number of episodes a year, which is quite substantial in individuals who are having very frequent episodes. And also anecdotally, one of the things that can be helpful, particularly in individuals who have very prolonged bouts, so these bouts typically last for days or weeks. Occasionally we do see individuals who have bouts for months, and intravenous methylprednisolone can be helpful in terminating a bout. And I feel like I've rattled through a range of different sleep disorders very fast, so I'm going to stop there. Just to conclude that our understanding of therapeutic options is really very rapidly progressing at the moment, that a lot of these novel agents hold significant promise, and as I said, not all insomnia is insomnia. For those individuals in whom you are wondering whether there may be something else going on, please refer early. Thank you.
Terrific. Thank you very much for a fascinating talk. I think we've probably got time for one question. Yeah, so Rich had his hand up. So for those at the back, there is lots of space at the front, so please do come down.
Thanks for the talk. I used to work in a complex trauma clinic, and it was quite often that prazosin would be prescribed for PTSD nightmares. I wondered what your thoughts were on that. But also, a lot of people self-medicated for insomnia with cannabis, and also wondered thoughts are of cannabis and sleep architecture.
Yeah, I mean, I think to answer your second question first, the data on cannabis is very, very mixed, and I think it relates to the proportions of THC and the different CBD variants. Certainly there have been some studies that have demonstrated improvement in sleep architecture. There have been lots of studies that have also demonstrated a worsening of sleep architecture. In fact, we're at the moment involved in a commercial trial for a cannabis-containing compound. So I think it's a case of watching this space. In terms of prazosin for PTSD-associated nightmare disorder, so in fact, there was a randomized controlled trial done at the VA a few years ago, which actually demonstrated no benefit whatsoever. But having said that, you know, we've all seen individuals who've done very, very well on prazosin, and the AASM actually a few years ago produced some guidelines. Now, for nightmare disorder in general, the treatment for which there is most evidence for is image rehearsal therapy, so a non-drug-based technique. But there is evidence for prazosin, there is evidence for trazodone, and there is evidence for a range of different antidepressants and antipsychotics, as well as very simple CBTI. By improving sleep stability, you can have a marked improvement in nightmare disorder. And the different treatments relate to whether or not this is PTSD-associated nightmare disorder or non-PTSD-associated nightmare disorder. So I would encourage you to go and have a look at that AASM consensus paper.
Lovely, thank you very much. So I'm really pleased